Welcome everyone to lecture 44 of the series on fluids and electrolytes. These lectures accompany my book, Manual of Fluid, Electrolyte, and Acid-Base Disorders, a Pathophysiologic Approach to Common Clinical Problems. I'm Dr. Mohammad Tinawi. I'm a nephrologist in Northwest Indiana. If you would like to purchase the book on Amazon, please click on the link below. If you haven't done so already, please subscribe to this channel. We are still on Chapter 6, Hypocalcemia and Hypercalcemia. Today we are going to finish our discussion of hypercalcemia. Now, how do we diagnose hypercalcemia? Last lecture we talked about the causes. Well, if you have calcium over 10.4, you have a diagnosis. It is better always to use ionized calcium for the diagnosis of hypocalcemia or hypercalcemia. So if you have ionized calcium over 5.3 milligram per deciliter, then you have a diagnosis of hypercalcemia. Now, what do we do for workup? As usual, we need a history and physical. Is there history of prior hypercalcemia? Do you have history of malignancy, excess intake of calcium, antacids, vitamin D? Is there history of sarcoidosis, immobility, thiazide diuretics, etc.? Now, again, hypercalcemia of primary hypoparathyroidism, HPT is hypoparathyroidism, is chronic and mild. Most patients don't have symptoms. We can see mild to moderate hypophosphatemia because, again, PTH is phosphaturic. So when you have high PTH, you are going to lose more phosphorus in the urine and get a little bit of hypophosphatemia. Now, to make a diagnosis of primary hypoparathyroidism, we need the following. I mean, usually you need to see hypercalcemia, okay? You need to have elevated PTH. You have then to prove that you have an adenoma or hyperplasia of sorts of the parathyroid glands. You are going to do an ultrasound of the neck with focus on the parathyroids, not the thyroid. I mean, you are going to get the thyroid, but you want to focus on the parathyroid. And you can do a nuclear medicine scan with technetium 99M. This will help localize a possible parathyroid adenoma or adenomas. Okay, then once you are certain of the diagnosis, you really have to do a 24-hour urine collection for calcium. If you don't have hypercalciuria, if you don't have increased calcium in the urine, really you have to count from 1 to 10 before you send anyone to surgery, okay? To have like an ironclad case, you need the hypercalcemia, you need elevated PTH, you need localization, and you need high urine calcium. Now, there is a variant of primary hyperparathyroidism called normal calcemic primary hyperparathyroidism, and in that case you have elevated PTH but normal serum calcium, so we should be at least aware of that. Now, it's not difficult to make a diagnosis of hypercalcemia because whenever you order a basic metabolic panel, basic chemistry panel, you are going to get calcium. Now, when we get calcium, we get other electrolytes. So we get the sodium, we get the potassium, but we are going to order magnesium and phosphate because these three things, as I said many times, magnesium, phosphate, calcium, they are related. We need to check albumin and creatinine because chronic kidney disease has many implications. Now, we should correct serum calcium to albumin. So if we have hypoalbuminemia or hyperalbuminemia, like we said before, we need to correct calcium. And if we can measure ionized calcium, it's preferable. Now, in patients on hemodialysis with hypercalcemia based on high ionized calcium, if we just go by total calcium, even if we correct it for albumin, we are going to misdiagnose many of them as normal calcemic. So Obi et al., they suggested a formula, you can see that on the screen, for corrected serum calcium. It's different from the simple formula I mentioned in lecture 1 on calcium. Now, once we have a diagnosis of hypercalcemia, the next step will be to check PTH. Okay, if you have high PTH, think of primary hyperparathyroidism or possibly familial hypocalcemic hypercalciuria. All other cases, if you have malignancy, if the patient is on a thiazide, if you have immobilization, anything else is going to suppress PTH. So hypercalcemia would suppress PTH. This is the normal response, unless the cause of hypercalcemia is high PTH in the first place. Okay, clear enough. So what else do we need? 24-hour urine collection is critical if we are suspecting primary hypoparathyroidism. Why? Because if we have manifestations of hypoparathyroidism, but then we measure urine calcium and it is low, then maybe we are dealing with familial hypocalciuric hypercalcemia. Those cases don't need surgery. You are not going to send them for surgery. Maybe check other family members, maybe do genetic testing. Now, if you cannot do a 24-hour urine collection, you can do a random urine calcium creatinine ratio. In hypercalciuria, the ratio should be over 0.03. Now, I'm going to tell you something. I'm not going to send someone for surgery without doing a 24-hour urine collection. Okay, if someone will go for surgery, I really need a 24-hour urine collection for calcium. But urine calcium and creatinine ratio is a good first step. If you are suspecting a malignancy, measure PTH-related peptide. This is an expensive test and it's going to take several days before it comes back. So do not delay treatment until you get the results. Elevated alkaline phosphatase suggests bone lysis. Now, if you are suspecting that the hypercalcemia is due to elevated calcitriol level, like sarcoidosis and lymphoma, by the way, this is not very common, then measure 125-dihydroxy-D. This is one of the few instances where you actually would measure 125-dihydroxy-D. In other cases, we just measure 25-hydroxy-D if we are suspecting vitamin D toxicity. Again, 125-dihydroxy-D is an expensive test and takes several days to come back. Don't order it very often. If you are not suspicious of something like sarcoidosis, borreliosis, histoplasmosis, tuberculosis, lymphoma causing the hypercalcemia, do not order it. Do not order it in patients with chronic kidney disease or advanced chronic kidney disease. It's going to be low. Okay. Again, and I've mentioned that several times now, we have to distinguish primary hypoparathyroidism, which usually requires surgery, from FHH. Urinary calcium is high in primary hypoparathyroidism. PTH is high, urine calcium is high, over 200 milligrams per 24 hours, or a ratio of calcium to creatinine in the urine over 0.03. Now, in FHH, it's inappropriately normal or even very low. And if you are doing a ratio, it is less than 0.02. Genetic testing and detailed family history, you need that for the diagnosis of FHH. Again, if you measure urine calcium, it's 20. I really would hesitate before sending someone for surgery for primary hyperparathyroidism. It's probably not. Now, let's talk about management of hypercalcemia. The most critical step is volume repletion with saline. These patients come to the hospital, they're dehydrated, calcium is high, start them on saline. Now, loop diuretics in the past, everyone said give saline, give loop diuretics, because loop diuretics will increase excretion of calcium in the urine. They're not terribly effective and they will make dehydration worse. If you must use them, hydrate the patient first. If the patient is hypervolemic, then use a loop diuretic. But don't start with a loop diuretic. Start with hydration. In severe hypercalcemia, you are going to use a bisphosphonate, and intravenously, of course. And we have two. We have intravenous pamidronate or zolindronate. Pamidronate, the dose is 30, 60, or 90. And with the zolindronate, or zolindronic acid, is 2 milligrams or 4 milligrams. So usually we use these for malignancy-associated hypercalcemia because the hypercalcemia is usually severe enough to require this kind of intervention. What do bisphosphonates accomplish? They inhibit bone resorption and synthesis of calcitriol, but they take 2 to 4 days to work. So if you give it on day 1 and day 2 calcium is unchanged, don't keep giving it. Otherwise, you will end up with hypocalcemia. Okay, so be a little bit patient. Okay. Bisphosphonate should be used with caution in patients with CKD, especially advanced CKD, because there has been cases of focal segmental glomerulosclerosis, especially the collapsing variant. If you must use it, use a lower dose. I usually use 2 milligrams of Zometa, zolindronic acid, and rather than infusing that over 15 minutes, I infuse it over 2 to 4 hours. And so far, I've done it many, many times. I have not seen acute kidney injury or worsening in renal function. So just be careful with bisphosphonate in patients with CKD. Denosumab is actually preferable to bisphosphonates in patients with chronic kidney disease. The problem is it's very expensive, it's subcutaneous, and hospitals, they just would not get it for you. So this is why we are stuck with bisphosphonates using lower doses and slower infusion. Okay, if I could get denosumab, I'm not going to use bisphosphonate, but I can't. So denosumab, or Prolia, the trade name, is a fully human monoclonal antibody. It targets the NF-kappa B ligand rank L, rank ligand. It is an effective option for refractory hypercalcemia, parentheses, if you can get it. Denosumab can result in severe hypocalcemia in patients with advanced chronic kidney disease. So many patients with CKD get Prolia as an outpatient for osteoporosis. You have to be careful. Calcitonin salmon really has fallen out of favor. You get tachyphylaxis quickly. It is expensive. You can use a sub-Q or IM. I don't use it anymore. Corticosteroids are magical if you have granulomatous disease like sarcoidosis. They inhibit calcitriol production. They work really well. Now, if you are really stuck, you have recalcitrant hypercalcemia, especially someone with the advanced CKD or acute kidney injury, then you can use dialysis. You just lower the calcium bath, and dialysis is very effective. Now, once acute and severe hypercalcemia is treated, we should search for a cause. Patients with symptomatic primary hypoparathyroidism, those with nephrolithiasis, osteoporosis, fractures, hypercalciuria, severe hypercalcemia, usually again with primary hyper, it's not severe, we treat them surgically. You need the major thing for the success of surgery is the surgeon. Okay, so you have to send them to a surgeon and to a center where they do a lot of that. Some general surgeons do it, endocrine surgeons and ENT doctors, some of them are really good at parathyroidectomies. Okay, so unless you have a contraindication, you are going to do surgery. If you have a contraindication, you are going to use cinacalcet. Cinacalcet is a calcium mimetic drug, and it increases the sensitivity of calcium sensing receptor to extracellular calcium. In other words, it will make the parathyroid think that there's too much calcium, so they are going to turn off PTH. We use it a lot in secondary hyperparathyroidism in dialysis patients, okay? But sometimes it's been used with success in patients with primary hyperparathyroidism. There's really no evidence that it would reduce kidney stones, for example. It is usually well tolerated. 25% of patients can get nausea, vomiting. Most of the side effects are GI. The price has really come down since it's become generic. So it is an option if you have someone with mild case, someone who is really debilitated, you cannot do surgery. And it is a solid option for secondary hyperparathyroidism because you are not going to do surgery unless the case is recalcitrant and it fails vitamin D analog and cinacalcet combined. A 5-year study in patients with mild to moderate primary hyperparathyroidism showed that cinacalcet reduced PTH, normalized calcium with no change in z-scores of areal bone mineral density, meaning it stabilized the bones, stabilized and prevented further bone loss. And cinacalcet was well tolerated. I'm going to end here. Next lecture, we are going to do some cases. See you then.